All right. Again, this is the top 10 essential infection control strategies for improved safety in the dental practice. We're recording this on February the 28th, 2024. I'm Dr. Kirsten Rolling. I'm the Chief Education Officer here at Dental CE Academy. I'm a public health dentist here in Phoenix, Arizona as well. I was the chief for the Office of Oral Health for Maricopa County's Public Health Department. It's the third largest health department in the U.S. And part of my job time to time was to accompany the dental board to inspect dental practices that received some sort of complaint. I'll be sharing some of those experiences with you this evening. I like to make this class as interactive as possible, so make sure you type your questions in the chat area. For those of you that are watching the recording later, the way you'll get your CE credit is to scroll below the video player to the instructions section. Number 2 will be your handout. Number 3 is the quiz. You'll access the quiz for on-demand credit directly from our website. For those of you attending live, we are going to email the quiz with the CE instructions to all of you at 7 o'clock Pacific time. We are required for this evening to audit your attendance, so please be sure that you are here. Please do not reach out through the website for assistance until we get those emails sent out to you. And if you have any questions during the presentation, please be sure to type them into the chat area. I'd like to thank Aerosol Assist Pivatool LLC for supporting our efforts to improve infection control and dental practice safety. And this Saturday, I'll be presenting our 3-hour course from 8 to 11:30, 3.5 hours, infection control, comprehensive. This course I put together based on the questions that I've been asked over the last 20 years teaching infection control. And I realized we really have 10 focal points that we should address in our practices very simply to upgrade what we're doing. And I based these on the questions that I received from all of you over the years. I recommend that you use Chrome browser for all of you. And if you have any issues with your hearing this evening or your video, log out and log back in. We do have an engineer on every one of our courses. If we have an issue, we're going to let you know. If you are having an issue, it's on your side. So be sure that you log out, log back in, and use Chrome browser. There's my conflict of interest and financial disclosure statement. Again, I am the Chief Education Officer here. I have not received an honorarium, nor do I have a financial affiliation with the sponsor. And our agenda I just reviewed. CE credit instructions, we have changed. We are auditing attendance this evening. We are required to. Please be sure that you are here. Once you log out, wait about 30 to 45 minutes because we'll have to check everyone's attendance and you will receive an email from us from infection control at dentalcenow.com to complete a quiz. There are the learning objectives this evening. So again, I've identified these top 10 strategies: surface disinfection, hand hygiene, PPE, sterilization, pre-procedural rinses. We're going to talk about nasal decolonization, handpieces, water lines, vacuum lines, and aerosol. And again, you're logged in from 5 to 6 for CE credit. That is correct. So 6 to 6:30 is promotional. We hope you'll stay on. Dr. Arguello will talk about aerosol in more detail. He is a general dentist in Florida. He found that every Friday he was feeling ill and he realized he was exposed to the aerosols. So he developed a device that addresses aerosol in the patient zone, and we'll talk about that towards the end. Okay, let's talk about surfaces first here. The problem here that we need to address is the level of contamination that may be left on our environmental surfaces that can help disseminate disease transmission. And this contributes also to aerosol contamination. So if we are not decontaminating our surfaces and we're leaving behind contamination, when our HVAC turns on, when we walk by a surface, if we are using a high-speed handpiece or an ultrasonic skiller, for instance, that can re-aerosolize anything that's remaining on your environmental surfaces, and that's your clinical surfaces as well as your housekeeping surfaces. Pathogenic spores can live and contaminate your environment for months to years. That includes Clostridium difficile spores. So if you were not familiar with that, it's a course I happen to teach because I survived a life-threatening illness, but it's an important one, right? Our patients are getting antibiotics from us, and it puts them at risk for Clostridium difficile. Your current wipes that you're using may not be sporicidal, and they're also potentially toxic. And the majority of you are using quaternary ammonium compounds. So type into the chat area what surface disinfectant you're currently using, and I'll let you know. Okay, let's see what you're using. We have Optum, we have Cavi wipes, we have Purple Tops, we have Optum Cavicide Cavi wipes, Optum Cavi wipes, Cavicide, Lysol wipes. Okay, well, EnviroCleanse I'm not familiar with, but I'll take a look. The majority of you are using Cava wipes and Purple Tops, which we call. We've got one warrior here using hypochlorous acid. Yay, Robert. Cava wipes are quaternary ammonium compounds, and although they are excellent disinfectants, they are not sporicidal. They're also quite toxic. And if you look in your folder, we've included information in the course folder about quaternary ammonium compounds. I present a course on hypochlorous acid, as you'll see. But strategies, again, use hypochlorous acid versus QACs. Why? Hypochlorous acid is non-toxic. If you're using a hypochlorous acid product that is on EPA list K, it is then registered to be sporicidal against Clostridium difficile spores, especially if you're using it with an electrostatic sprayer as well, because you'll reach 30% more of your surface. I'm going to play a quick video here for you about C. difficile spore contamination in the dental practice and why it's important that we do mitigate for these spores. And for some of you, it may be a review. You may have taken another class from me. I'm going to be in the background here. If you're not able to hear this on your device, we'll put the link in the chat area.
So let's talk about community C. diff if we could for a moment. What are the risk factors in the community, and how do they differ in the community versus the hospital-based population here? Dale, you want to start us on that?
Yeah, that's a really good question, because there's two factors that we need to have in order to get C. diff. One is antibiotic use, and the other is exposure to the spores. So the spores are ubiquitous. They're out in the environment. They even contaminate at a very low level some foods, meats, root vegetables, lettuce, and those are probably how patients in the community get exposed. They, on the other hand, when the CDC has looked at community-associated C. diff, they found that about 80% of these patients have had an exposure to healthcare as an outpatient. So it's doctor's office, dental office, and chronic dialysis units, ambulatory surgery. And this is where you have two risks. One is that somebody's going to give you an antibiotic, and those are called doctors. And,
We
and
hope it's only done.
they put people at risk of C. diff. And the other exposure is that the healthcare environment is more contaminated with C. diff spores than is the environment outside of healthcare.
And I think it's worth noting, Paul is nodding his head, he has a lot of nodding. It's not just the people who are in the healthcare system. It's not just the people who got the antibiotics. They go home. They've got spores, and then their families are exposed. So it seems to me that that's part of the issue, isn't it?
And those
Yes.
spores can live for a significant period of time on many different surfaces, even when exposed to sunlight. And you'll see some data that says alcohol and certain products can kill the spores, but that it really has to be used properly, where the liquid sits on a surface for a significant period of time to have its effects. So the fact that the spores can be taken home with you on your lab coat and in your house and on surfaces for 6 months or a year or longer certainly put people at risk.
Okay, we have a comment here. EnviroCleanse A is hypochlorous acid. So be aware that EnviroCleanse A and other products that are hypochlorous acid may be an excellent disinfectant, but may not be sufficient in concentration to kill the spores. And I'm going to contact EnviroCleanse A to see. It says it kills C. diff. So does the same packaging on Cava wipes. However, C. difficile bacteria is an anaerobe, so it dies on a surface. It's the spores that we have to be very, very concerned about, as we heard over the video here, because these spores are like cocoons and they can survive the gastric acids of your stomach, high temperatures, in some cases even bleach. So hypochlorous acid, we had a question about what concentration is sufficient. It depends on the product. What is the kill time? Depends on the product. Some products require 4 minutes, right? Again, you have to be sure that that product is listed on EPA List K. So I can't tell you for sure that EnviroCleanse A is on EPA List K. It may be N, sufficient for C. difficile, but not the spores. And you can use the hypochlorous wipes for high touch areas, and then electrostatic sprayers. So let me show you how that works in terms of the sprayer. And again, if you're not able to hear the video, we will put it in the chat area for you. So this is a dental assistant. She is using an electrostatic sprayer in the dental practice. This sprayer, you put 4 tablets in the container here. It's about 1 liter. That'll make a concentration of 4,306 parts per million. If you are currently generating your own hypochlorous acid on a countertop generator, it is not a sufficient concentration to kill C. difficile spores. Now, the great thing about these electrostatic sprayers and this product is that you can use it on all surfaces. Electronics, your chairs, your flooring, everything. Front office, restrooms, etc. So you see her using it more as a fogger. The way you really want to use it is you'll stand about a foot away from your surface and completely spray down the surface. I'd also say get all this stuff off the counter that you don't need for each procedure, because it's just being exposed to aerosol that's not required. And there are some other links here for you. Clinicians report how to choose and use environmental disinfectants is an important one. Dr. Rella Christensen won't even use a quaternary ammonium compound, and she's not a big fan of the wipes because they're not efficient, they're not effective. These are some classes that I offer on our website at no charge if you want to learn more. We'll talk about hands now, and we have some questions. Barbara, there's no echoing in my background here. It would be on your side. Is ozone water acceptable? It's not EPA approved. So you want to be sure you're using something that's EPA approved for the purpose. 600 parts per million of Pivatool clinical cleaner will kill the spores. That's correct, but make sure you're using and make sure that it's non-toxic. Make sure that you are using a product that is on EPA list K. All right. What hypochlorous acid formula wipes used in a dental office that remain still and effective longer than 48 hours? So, Dr. Neal, take a look at the technology sheet that we've included, and you can reach out to me through the website as well. But I'm a fan of the NADCC tablets and the dry wipes that they offer, and they are recyclable materials, so they're better for the environment than the microfiber cloths. Okay, let's talk about hands now. So the problem with hands, number one mode of disease transmission in the healthcare setting. Bulk refillable soap dispensers, or what we call disposable containers that are refilled or not, can increase hand contamination because of the accumulation of biofilm. Hand hygiene must be a cultural practice in your clinic or your dental practice. If the leadership team is not washing their hands, the rest of the team will not. So it starts with leadership, and your patients are watching you. And if you go into some of the reviews on Yelp and Google, you'll see the low reviews, and some of them are, my dentist didn't wash their hands. My assistant touched their hands with their bare hands. I'll tell you, and I speak about this in my infection control class on Saturday, I was hospitalized very briefly for vertigo in September around Labor Day weekend. And I was kept overnight for observation, and not one medical provider washed their hands until I asked them to. They had alcohol, hand sanitizer on their carts. Not one washed their hands, and there were signs on every patient room that required them to do so. So again, it's really important that your patients see you wash your hands, but also understand that when we look at the chain of infection, again, the number one mode of transmission for disease transmission in our dental practices are our hands. And I know we're wearing gloves, but that is not 100% proof, right? What happens is that the germs or any of the pathogens that normally live in our hands or maybe colonized on our skin can rapidly proliferate underneath those gloves. They're dark, they're damp. You take your gloves off, you reach for your phone, or you touch a keyboard, and you're causing cross-contamination. And remember, dentistry is very procedural, right? We have tray setups. Those tray setups require sterile instruments and so forth. So again, hands through direct contact, indirect contact, very important that we wash our hands before we put our gloves on and after we take our gloves off. All right, so strategies here: implement hand hygiene routine, soap and water versus alcohol hand sanitizer. So alcohol hand sanitizer, I happen to have one here, 70%. If you are using it correctly, and by that I mean not using it like hand lotion, where you put a little dab here and you do one of these, and then you put your gloves on and you call it a day, right? The problem here is that you have to use it for the length of time that the manufacturer tells you. And if your hands are dried before that time, you've not applied enough and you have not used it long enough, and you probably haven't touched all the surfaces, cleaned all the surfaces that you need to, right? We also know that alcohol hand sanitizer is not sporicidal. So it will not kill C. difficile spores. Soap and water is thought to be a better alternative, and hospitals are revisiting this now because hospitals also have a Clostridium difficile spore problem. So as long as you're washing your hands under soap and water is flushing off the spores, that's thought to be potentially better. So there are a different set of eyes looking on this. CDC recommends alcohol hand sanitizer. Why? Because they know it improves compliance. They know that many facilities may not have sinks in their operatories. Some of you may not have sinks in your operatories. When I practiced for the health department, my operatory might have been in a school coat closet, all right? So I didn't have sinks. It was the best thing I had. My mother would say it was better than a poke in the eye with a sharp stick, right? But it has to be used correctly. And we want to replace bulk refillable soap dispensers or disposable containers at risk for contamination due to biofilm. And I'm going to show you a couple of quick videos here about bulk soap dispensers and why we need to reconsider the way that we're dispensing our soap and how it may actually lead to more contamination. So the first one is Dr. Gerba, who is at the University of Arizona here.
You're most likely to come in contact with fecal bacteria with a refillable soap dispenser than anywhere in a public restroom. Because you really can't tell contamination's occurring. You can't see the bacteria growing in there. So you never really know if there's bacteria or not. That's why using a sealed soap dispenser is the way to go. Well, it's been found that really cleaning regular refillable soap dispensers doesn't really get at the bacterial problem because biofilms develop inside these soap dispensers. And even if you clean them and disinfect them, it comes back right away, the bacteria. As soon as you put additional soap in these dispensers, the bacteria start growing right away. Well, I think there's definitely a risk to people getting ill from refillable soap dispensers because you find bacteria in there that can cause eye, skin infections, and wound infections. So I think the probability is there. And of course, it's been demonstrated in healthcare facilities. So we know the potential is really strong for this to occur. You know, people are going in there to remove things from their hands and they're putting them on. They're trying to take off fecal bacteria by washing their hands, and they're actually putting them on. So in a way, it's an oxymoron. You're doing the reverse of why you're washing your hands. Well, I really think bulk soap dispensers should be regulated. And in fact, I don't even think they should be used. I think we really should go to sanitary seal soap dispensers that you can't refill all the time, because that would eliminate the problem of the growth of the bacteria in these dispensers. But I think it's really the responsibility of facility management is to put the proper type of soap in these facilities so people don't increase their exposure to large numbers of bacteria. The greatest exposure to fecal bacteria for many people may be washing their hands.
Some of you may not be able to hear the video. If you have something running in the background of your browser, it could be Zoom. We do have the links to this. It was in the slide before this. We do have it closed captioned, but again, you may not be able to see it on some of your devices. So refer to your handout. Okay, had a question about any links I can offer you. There are half a dozen there for you. Take the course that I present on hand hygiene. Again, it's at no charge to you, and there is the link as well. So if you're using disposable soft soap dispensers that are sitting on your counter, you're at a potential risk. The same with the bulk soap refillable dispensers. And we had a question, does that also correspond to alcohol hand sanitizer? And it does. So if you're refilling those, you're all using the same. The best thing that you want to do, and this is a breakdown, hand washing versus alcohol-based hand rubbing, it gives you the benefits of each. Again, this is according to a study in NCBI. But overall, the CDC believes it raises the compliance, right? But again, if you're using these bulk soap dispensers or the refillable dispensers for your alcohol, similar to these, it's the same issue, same concern, all right? So you want to get rid of those, and you want to consider a touchless system. Again, we said hands are the #1 mode of transmission. If we're applying more contamination to our hands than we're taking off, it doesn't make much sense. This is a great system, being able to use a completely touchless system, but their soap is dispensed from a refillable dispenser, which I'm sure you've seen. So not so great on that side. And let's see if we have any more questions. So there are plenty of studies that tell us that we need to be using a touchless system. We've been taught for years not to refill soap dispensers. What's going on? Well, obviously, Julia, there are a few of us that obviously didn't get the obvious message here. Sorry to tell you. Yeah. And if you walk into any clinic, which I have walked into plenty, I'll see these soft soap dispensers and so forth, especially the older clinics. Is it the same risk at home? Yes. Public is worse. I don't know. I don't have the studies to compare, but biofilm is biofilm. So it doesn't care if it's in your home or in a clinic. But I'll tell you, if you go into a restaurant the next time and you see these, Starbucks is famous for these. Look at that little glass key. It's green, it's black, it's slimy. There's a reason for that. How do we know the soap at the soap manufacturing factory is not contaminated when placed in the container? We don't. We don't. But the fact is, if you're using that as a reason to continue to use these refillable, it's not. That's an oxymoron. I would be using a touchless system. They are required not to sell you contaminated soap. So I think that is probably not the best angle. I would use something that's touchless. Okay, let's go on to PPE. Here's the problem. We are in a procedural occupation. We're exposed to direct contamination. We're exposed to indirect contamination. And PPE is an intervention. When we look at the chain of transmission, it's an intervention to prevent disease transmission because of this contact, whether it's direct contact with the patient or indirect. Also with fomites, so inanimate objects, surfaces, instruments that may be contaminated equipment, and of course, aerosol. So we use disposable gowns. Our forearms should be covered chair side. When we see the amount of aerosol that is being ejected from someone's oral cavity and the instruments that we're using, and your forearms are not covered, they're contaminated. And I don't think you're scrubbing up to the bicep area, right? So you're going to go to another patient and another patient, another patient. You're reaching across that patient and so forth, and you're going to have lunch. What I want to drive home today is this information is, of course, to protect the patient. Absolutely. It's also to protect you all. And I created these courses after surviving a lethal Clostridium difficile infection that followed a dental procedure. And I became infected 30 days after finishing an antibiotic and within 48 hours of returning to that practice. Was I a carrier? We don't know. Carriers represent about 0.4 to 15% of the general population. The majority of the folks that get Clostridium difficile are the folks that were described in the video, the Contagion Live. It's contamination in the environment and taking an antibiotic, all right? So we want to be careful because we can take this stuff home with us. It doesn't just stay in the dental office. All right, so cover your forearms. Make sure those gloves, cuffs are covered over the elastic of your gowns. Replace that gown at least one daily or more often if it's visibly soiled. That's the CDC. If you're working with ultrasonic scalers all day, our dental hygienists, you may want to replace it more often. I recommend shoe covers because the contamination can follow you home in your vehicle and on into your home. And you just heard one of our experts talk about that. The C. diff spores can be on your lab gown, your scrubs, etc. Face shield, obviously to protect our eyes, our face from contamination and any objects getting in our eyes. Laundry, keep your laundry separate from your household laundry. So if you're not provided scrubs in your dental practice, and not all states are required, change at work into your home clothes, your street clothes, put those scrubs in a plastic bag and keep it separate from your home laundry. Use a Lysol laundry sanitizer and hot water. And there is a citation there for you, of course, and our course that we offer 2 Saturdays a month. The next one actually is this Saturday, and there's the link. So this is how we should look, chair side, right? Cuffs of gloves come up over. It sounds like it should be a no-brainer, but there are many offices out there where you're not wearing this sort of garb. Your forearms are exposed. What about lab coats that are used at work and washed at work? That's fine, but I would make sure, again, that your wrists are covered with your gloves. It's a seal, all right? So if that lab coat sleeve is hanging open, you know, there's a chance that contamination can get there and you're going from patient to patient. All right, so this is how you don't want to look chair side. These forearms are getting blasted with aerosol and contamination. Okay, sterilization, here we go. And I'm going to move a little bit faster here for. Here's a question I'm always asked. Instrument packets, should they be faced up or face down? And I should have reminded you all, I was a registered dental assistant way back when dinosaurs roamed the earth. Prior to PPE, we put our bare hands in bloody mouths, no mask, no eye protection, no gowns. And this was not a question that I was always faced with as a dental assistant, but in recent years, I'm asked face up or face down. Most of your autoclaves came with these racks, right? You probably don't even know where these racks are. I know in many of the practices I was in, we didn't even know they existed, right? If you use these racks, your packets are going to be vertical, and then it's a non-question. If you're using cassettes, some of them make cassette racks as well. Some of your autoclaves will tell you not to put instruments on or packets on the very bottom because it will stain, etc. Or they can, some cases, melt some of the instruments that you're using. So refer to your manufacturer's instructions. All right, what's the problem here? Instruments that are not properly sterilized pose a safety risk to patients and staff. And I'm going to play another quick video. So for those of you that cannot hear it, I will put the link in the chat area for you. This is a dentist in, I believe, Tulsa, Oklahoma, who decided to do his own thing. And here are the results.
Health officials are saying that a Tulsa dentist may have exposed thousands of patients to life-threatening diseases ranging from HIV to hepatitis. ABC's chief health and medical editor, Dr. Richard Besser, is here with this disturbing story this morning.
It is disturbing. You know, I've spent my career in public health, and it's not hard to prevent infections in dental offices. But what they found here was absolutely shocking. Dr. W. Scott Harrington has been a trusted oral surgeon for 36 years, but now authorities believe he may have exposed thousands of patients to potentially deadly infections by allegedly using rusty instruments which weren't cleaned properly. Letters are being sent to 7,000 Oklahoma patients recommending they immediately be tested for hepatitis B, hepatitis C, and HIV, after one of his patients with no known risk factors tested positive for hepatitis C. In addition to allegations that he cleaned his instruments by improperly bleaching them, which caused them to become porous over time, he's also accused of reusing needles and vials.
The instruments that came out of the autoclave were horrible. I wouldn't let my nephews play with them out in the dirt. I mean, they were horrible. They had rust on them.
He even reportedly had medications 20 years past their expiration date and allowed unlicensed assistants to give IV medications. We reached out to Dr. Harrington, but he did not return calls.
So 7,000 patients have gotten these letters to get tested for HIV, hepatitis C, hepatitis A. I mean, what are the chances more patients are going to test positive, given those conditions?
Yeah, I mean, there are a couple of disturbing factors here. You know, many patients in his practice have HIV and hepatitis C and hepatitis B.
He was treating a higher risk population.
He was, and he had instruments set aside for those patients and other instruments for patients where he didn't know that whether they were infected or not. That's very dangerous. All instruments should be treated the same. You know, last summer there were 8,000 patients from Colorado who were notified, and thankfully there, none of them were infected. Here, there's a much higher chance someone could get sick.
But I would have thought soaking instruments in bleach would have killed anything. We keep hearing bleach is the only thing that kills everything.
Well, for a lot of things, bleach is the way to go. But these instruments have to go into something called an autoclave, which uses pressure and heat. If you use bleach on them first, it disturbs the outside of the instrument so that the autoclave no longer works.
And they become porous and things can get inside.
They can seep in, and then the heat and the pressure don't kill those germs.
So what are you supposed to look for, Rich? I mean, I go to a dentist office, and usually I've got so much stuff in my mouth I can't see what's going on.
A couple clues to look for. The first thing, if you ever see rusty or old instruments, that's a warning sign. The other is if your dentist isn't wearing gloves or isn't changing gloves between patients, find another dentist.
So he should do that in front of me?
Yeah, definitely. You should see that they're putting on fresh gloves.
Okay,
definitely.
and pay attention to those instruments.
That's
All right,
right.
Rich, thanks so much. Disturbing news. We'll keep on top of it.
Okay, so good questions here and comments. I did forget to say, be careful wearing jewelry underneath your gloves and so forth. I wear jewelry around my neck because you can't really clean this jewelry sufficiently. Also, nails should be short. Acrylic nails, gel nails are a risk, especially because they're absorbent at some times. If you're wearing nail polish, make sure it's not chipped because that can also harbor pathogens. I used to take round polished toothpicks to work, and I'd keep them in every drawer, and we would clean our nails at the beginning of the day. That's a good practice as well, and at the end of the day. And got someone here who brings 2 lab coats interchangeable, blast them with the hypochlorite acid. Yeah, I can't comment. I don't have data to tell you, Carlemy, but I would tell you that it's, I think, a good practice at least to try to address the aerosol. But in my case, I prefer the disposables. A comment here from Michael. I recall mid-70s we were taught surgical scrub before first patient of the day and before first patient after lunch, then wash hands thoroughly between patients. No PPE, right? I used to get one glove during surgical procedures as an assistant, and then we autoclaved the glove in a Harvey, in a chemclave. That was 1982. All right, so again, instruments that are not properly sterilized pose a risk. Strategies here: make sure that you're spore testing your autoclaves at least weekly. That's a CDC recommendation, if not daily. If you are processing quite a few instruments here at the county, we processed 3,000 a day. I implemented daily spore testing. They do not have in the CDC the amount of instruments, so you have to use your own judgment, but at least weekly. Daily, weekly, monthly, and annually maintenance is required of your autoclaves. So I recommend sending them in once a year for a tune-up. Have them calibrated, have them look at the gaskets, and so forth. And make sure that you are using the racks to ensure airflow between your packets. And we have links here for you as well. And the link to the video, The Dirty Dentist, for those of you that can't hear it on your device. And there's the infection control course again. Okay, pre-procedural rinses. Let me make sure I've addressed all the questions here. So yes, spore testing, it is a must to record the results. And I'm going to give you the recommendation, and this is something I go in much more detail about. One of the things I looked for when I inspected a dental practice, the first thing I went to when it was an allegation around infection control was I looked at your autoclave. And if it was not well maintained, I'm going to look a lot deeper everywhere else, because your autoclave is the workhorse. If it's not working properly and you are subjecting patients potentially to instruments that are not sterilized, in some cases, in some states, that is considered assault and battery. So I have to look at everything else now, because obviously you're not in compliance. I've seen mold grow in the tubing, etc. So again, assign that task to someone in your practice and have them record every bit of maintenance that's performed on those devices. All right. Yep, there are several offices that do not have sinks anymore in their dental practices, and apparently they haven't heard of Clostridium difficile, which is a terrible thing. Okay, let's talk about pre-procedural rinses now, and there's controversy around this. The problem here is that in our dental practices, we can be contaminated by potentially harmful bacteria, viruses, SARS-CoV-2, etc., because of aerosol-generating procedures from our handpieces, our ultrasonic scalers, contaminated water lines. And the strategy is that if we could have our patients use a rinse to help dampen down any aerosol that may include whatever they have on board, right? So there are antiseptic agents that may help reduce temporarily the bacterial or the viral burden in the oral cavity that can be included in these dental aerosols. Now, the CDC believes that this is inconclusive, right? The CDC believes that we have data that shows that we can do this, reduce the levels of bacteria and viral loads, but they're not ready to step out and say we should be doing it, okay? Now, here is a link to the Science Pre-Procedural Mouth Rinses. So at the early days of the pandemic, what was recommended by the American Dental Association: hydrogen peroxide, which was banned in Canada, it's ineffective; chlorhexidine gluconate, which is a poor antiviral; and povidone iodine, which is efficacious, but it stains, etc. This is a course by Dr. Moskowitz, Oral Rinses, What's Safe, What's Effective. He goes through every antimicrobial known to man, just about. He is the chairman of Iotech International Molecular Iodine, and I've worked with him for 5 years. He presents this course every month. It's the best 1.5 hours you could take. So if you haven't, it's available live and on demand there. And he has some of the information that I'm sharing here with you: molecular iodine versus essential oils, cetylpyridinium chloride, and so forth. And you can see the breakdown, all right? Iodine, molecular iodine, completely effective. Essential oils, ineffective for unrhinovirus after 30-second contact. CPC, 750 times less effective. So again, he breaks all of these down. Cetylpyridinium is not as effective, and this is a question from Parmesia, relative to molecular iodine. Have Dr. Traeger, who uses it as well. Here's the breakdown: Staph aureus and poliovirus. And this is molecular iodine. Again, complete inactivation on poliovirus in 5 minutes and 30 seconds. Staph aureus. Okay. Molecular iodine versus chlorhexidine gluconate. There's the breakdown for you. Again, molecular iodine comes out the winner each time. And then as antiseptic rinse efficacy, there it is for you. Chlorhexidine gluconate, CPC, chlorine dioxide, povidone iodine, hydrogen peroxide, and stabilized chlorine dioxide. For molecular iodine in the case of FN and Prevotella intermedia, complete inactivation. Again, if you have questions about certain chemistries, I would urge you to take the courses here. And here's SARS-CoV-2. And this particular study was done at Utah State University at their Antiviral Research Institute. But also, Dr. Rella Christensen has tested this molecular iodine as well, and has found it to be the only one that was effective against SARS-CoV-2 in the presence of whole saliva. So if you haven't taken the course, the link is there for you. Nasal decolonization is important because the problem here is that many of us may be colonized with various Staph aureus and other pathogens, including MRSA. And that means that your patients could be walking in the door with possible MRSA carriage in their nasal passages. Now, hospitals and medical centers now are starting to use products or having their patients use products prior to coming in for hospital procedures. My brother had a knee replacement in November, and he was required to use an antimicrobial for about a week, that he had to swab his nose, and that was what the concern was, because they can infect surgical sites or cause cross-contamination. Certainly those of us in dentistry worried about aerosol, now nasal decolonization is something that we're looking at. And there's a link from Arizona School of Dentistry and Oral Health, where I happen to be a public health preceptor, about this. So take a look at that. The mean rate of nasal MRSA carriage is approximately 4% among healthcare professionals, by the way. So topical nasal decolonization agents, they can be antiseptic medicaments, sprays. I know IoTech has a barrier cream that they've produced, molecular iodine. Musipuricin is another one that is used in hospitals. And there are some citations for you. And this is from Dr. Moskowitz. Again, the nasal cavity is a reservoir for SARS-CoV-2, so you can be fully vaccinated and still be a carrier. All right, more information here for you on decolonization of MRSA in the nasal mucosa. Povidone iodine versus molecular iodine. Molecular iodine came out ahead. Yes, so there's spore testing. OSHA is to protect the employee, right? And spore testing is required. It depends on your state as well. So we can't just say 3 years. I would be keeping them forever. And again, if you are ever on the receiving end of an allegation and you're inspected, you want to make sure that you have all of that in front of you. And I want to tell you all that if you are an associate or you are a dental assistant and something happens and you're working in a condition like Dr. Harrington, and you know that it's not right, you're required to report it, right? So in dentistry, when you relicense or you become licensed, you sign an affidavit that states you understand your state statute and that you agree to report. If you see something, you say something. But if you're worried that you may lose your job, which is a real threat, and somebody else reports it, everybody in Dr. Harrington's practice received an allegation from their state's attorney general, not just Dr. Harrington. So you want to be advised, be proactive. The first agency you want to contact is your dental board and let them know, right? If you don't report it and somebody else does, you may find yourself not working, right? So we're required to report it. Okay, Handpieces here. How many of you are using Cava wipes on your handpieces instead of autoclaving? So Jean, you'll report it to, start with your dental board. Yes. The nasal decolonization products, I would take the oral rinses course and you'll get the full background on it. And that link is in your handout. Okay, so handpieces have to be autoclaved. Why? Because we have biofilm. Now, when I teach this course in infection control, we'll have at least 30% that have been told to use Cava wipes on their handpieces. That is not in compliance, right? Now, some of you may be using it and then autoclaving. That's not great either. It's not great for your handpiece. Check with your manufacturer. But your handpieces have to be autoclaved because internally we have to be concerned about biofilm. So if you're being told that you don't have enough handpieces, that's a red flag, right? Because you can potentially be causing cross-contamination that can make your patients very ill. We also have to be worried because those handpieces create more aerosol that is potentially pathogenic, right? And also contaminated water lines can contaminate your handpieces as well. Follow your manufacturer's instructions. Never wipe them down with Cava wipes or other disinfectants to replace sterilization. Barrier protection is inadequate. All handpieces must be autoclaved, including your dental hygiene motors. And there's the science for you. Okay, water lines. Let me double check your questions here. Hygiene only has 3 handpieces, and that's concerning. So again, your hygiene motors are supposed to be autoclaved. All right, water lines, what's the problem? Biofilm can occur in your water lines due to backflow, due to microbes in the water if you're using public water. The CD states for non-surgical treatment, the water that we use in our water lines should be at least equal to drinking water in terms of 500, less than 500 colony-forming units per mils of heterotrophic bacteria or less. Water must meet the EPA drinking water standards. Dental water lines are small in diameter. They're tiny. And they're slow flowing. So that allows time for the bacteria to attach to the inner workings of your lines, creating biofilm. Biofilm, by the way, can start in as little as 5 days. So if you have a brand new practice, you still need to be concerned. So after 5 days, they found that shouldn't be 200 CFUs per mil in 5 days. And there's the link for you. Pathogens that we're concerned about, primarily Pseudomonas, non-tuberculosis Mycobacterium, and Legionella species. Waterline contamination. This was a situation back in 2016, Southern California. This led to 221 lawsuits in a landmark Anaheim pediatric dentistry case. This was a pediatric dental practice. I believe they had multiple clinics, and they were not testing or treating their water lines. And 500 pediatric patients were exposed to potential infection. At least 71 children were infected with non-Mycobacterium tuberculosis, Mycobacterium abscessus, and some of them didn't develop infection until like after 30 days or so after their encounter with the practice. So we have to test our water lines. Check with your manufacturer. Test at baseline. If you have not tested yet, start now. Then twice monthly until you have 2 consecutive pass tests. Then you'll test quarterly and always after a failed test. You always have to shock, but you should test your lines before you shock them at baseline, then quarterly. And the contamination, if it occurs in your testing over 200 CFUs per mil, you're going to need to shock. So you can still be treating your water lines and have a failed test. All right. How do we treat? We can treat with tablets, straws, or liquids. I have no preference as long as you do it and you're testing. And also make sure you're flushing your lines at the beginning of the day, especially and between your patients. Now, note there's a difference between water lines and vacuum lines. All right. If you looked at your evacuation lines right now, your saliva ejectors, you'd be shocked at what you saw. This is dentistry's dirty little secret here. These are disgusting and they're highly pathogenic. And I would recommend, if you can go to either a system that you can autoclave these adapters or use the disposable ones, I would recommend it. But if you looked inside of yours today, doctors, you would be shocked at what you saw. And barriers don't protect you. Why are we worried about our vacuum or suction lines? We have retraction devices, but they might be 6 feet away from us. So we certainly don't want our patients putting their lips over the saliva ejector, because that backflow can go into their mouth. So the problem here is backflow, backflow, backflow. The solution here is make sure, first of all, that your vacuum is clean, it's operating. Disposables are available, as we said, the valve systems have a backflow preventer. Use non-corrugated tubing. Disposable traps should be changed weekly. Empty your vacuum trap monthly. Amalgam separators you should dispose of compliantly, and use a vacuum cleaner daily or more if required. If you've performed a surgical procedure, you're going to want to use the VacuSol or whatever you're using. Okay, aerosol here as we are wrapping up. The aerosol, our problem here, we have spatter, we have droplets, droplet nuclei, and ultrafine particles that embed preferentially in the respiratory tract. We are immersed in aerosol all day long in our dental practices, not just in the operatory, but when we leave the operatory, there is still aerosol that we have to be concerned about, because the aerosol, especially the ultrafine particles and the droplet nuclei, are very light in mass, so they float around our practices. They can head down the hall to your business office or reception area, or vice versa. It's a major source of dental practice contamination. It existed before SARS-CoV-2, and it will continue to exist further on. So a source of antimicrobial resistance as well, because this aerosol spreads pathogens that may end up on your countertops, in your hair, on the patient tray, etc. And water lines and handpieces that are not adequately cleaned and maintained are also a source of pathogenic aerosol. So when we talk about aerosol, the spatter, we're talking about the large particle sizes, over 50 microns. They behave like ballistics. They're going to bounce around in your operatory. Eventually, they run out of energy. Gravity will bring them down to Earth. Where is Earth? Hair that may not have a hair cover, a forearm, again, patient tray, etc. The droplets can hang around in the air of your practice for some time. The droplet nuclei are the evaporated droplets. They are highly, highly densely pathogenic, right? And again, they're going to also float around because their mass is very light. Ultrafine particles, very concerning. That's less than 2.52 microns. And again, they can embed very deeply into the respiratory tract, the alveoli. So when we approach aerosol, we're going to treat it in zones, that closest to the patient, the operatory, and then the entire facility. Monitor your air quality. There are air quality monitoring devices out there, IQ Air, that we work with. It's in your handout, offers air quality monitoring, a device at $300. You should effectively disinfect your surfaces so you don't re-aerosolize some of this. Waterline testing and treatment, as we said, handpiece maintenance and sterilization. You women of childbearing age, get yourself a nitrous oxide monitoring badge to make sure that your levels are below what's required, because you can affect your fertility. Pre-procedural rinses, as we said, in nasal decolonization is important. I broke down the particle sizes here for you. And again, the smaller they are, the more preferentially they will embed in your respiratory tract. So when I look at an operatory, I look at it in zones. We've got the patient zone here. The majority of what we're concerned about is in that very close zone, maybe 6 to 12 inches. This is where our faces are. You know this, you see your face mask. Notice their arms are covered. It's a good thing because they're in the zone. We want to try to use a device that's going to mitigate for the majority of this before it ends out in the outer, the operatory zone. All right, because what ends up in the operatory zone can very much lead to leaving the operatory and float around in your practice. So now we're relying on the HVAC. So again, the patient zone, we're going to look at devices that will mitigate for that aerosol before it ever leaves the patient's mouth. And you have those devices, and Dr. Arguello is going to talk about his device this evening, Aerosol Assist. In the operatory, you can have an extra filtration device. Again, look at IQ Air. They have an excellent one, and they'll provide you with a consult. You can check with them. And then your HVAC for the rest of your practice, all required. So those are the zones we're concerned about. So those are the patient zones. Definitely our intraoral suction, our high volume evacuation, and then any extraoral suction is important. For the operatory, we're going to look at air cleaning and filtration. Your entire facility, we're going to look at HVAC, air cleaning and filtration, and certainly monitoring your practice. And this is a link in your handout that will show you, this is what Dr. Arguello is going to be talking about for you in just a minute. If you look at the device on the left, this is an ultrasonic scaler without using any suction, including Aerosol Assist. And then the device on the right is with Aerosol Assist, and it's almost non-existent. So that's what we want to achieve. Okay. Any questions or comments before we bring on Dr. Arguello? Aerosol is also a problem with bathroom hand dryers, yes. Nasal decontamination products, I would look at our technology sheet that we have for you in your handout and take the oral rinses course, because Dr. Moskowitz will talk about that. In-office or mail-in spore test. So I prefer in-office, because if we're mailing it in and we're putting our instruments back into service and our autoclave fails, we're putting potentially contaminated instruments back out to be used. So I like in-office myself. Sterisil straw with filter water bottle. Okay, if you have any questions, what's the difference between wiping handpieces versus air water handles? The difference here is that your handpiece is internal. It creates a vacuum and it pulls in blood and saliva and creates bacterial biofilm, right? And you're putting that handpiece in somebody's mouth as well. The air water handle, I agree with you as well. If you're using it for retraction, the air water handle should be autoclaved, but many of you all are barrier protecting them. If it was up to me, I would be autoclaving those. And they make autoclavable ones that snap on and off. Okay, I would like to bring up Dr. Arguello, and he's going to talk to you now about Aerosol Assist. Again, I thank you for being here for this hour. If you have any questions or concerns, reach out to me through the website there. Let me go ahead and bring up his information. Hey, Dr. Arguello, welcome.
How's it going?
I am doing well. Thanks for being here tonight.
Give me 1 second. I'm trying to see if I can hear a little. I can hear fine, actually.
Can you? Okay.
Yeah.
All right, everyone. I am going to introduce you here to Dr. Arguello, and then we're going to play the video here about the Aerosol Assist. And we're excited to have him here. This is the first evening that they're joining us with the top 10 effective infection control strategies. And we really, really thank them for their support and for educating you all about aerosol. So this is Dr. Vigarny Arguello. He is a dentist, inventor, and an entrepreneur coming from a family with strong roots in medicine. He naturally gravitated towards the field of dentistry. He graduated from Florida International University, majoring in chemistry, and then Boston University Henry M. Goldman School of Dental Medicine. He is the co-founder of Pivatool and the inventor of the patented Aerosol Assist, and an innovative aerosol reduction device and an intraoral fluid removal device. His ultimate goal is to revolutionize dentistry by giving practitioners and patients the skills to eradicate dental anxiety, fears, trauma, and any other negative habit that limits the human condition. He currently practices in one of his practices in South Florida, and he enjoys multiple aspects ranging from treating patients, photography, psychotherapies, and of course, product development. So Dr. Arguello, I'll go ahead and play your video and then we'll take your questions. Thank you so much.
In this video, we will discuss how to use and maintain the Aerosol Assist. The Aerosol Assist increases safety and when used correctly increases work performance. We are confident that the Aerosol Assist will become a daily tool you come to depend on. The Aerosol Assist offers cost-effective aerosol suppression, intraoral fluid removal, and dynamic lip retraction in one easy-to-use, hands-free device. The best part is you do not need any specialized equipment or hoses to get started. If you have an HVE and a disposable saliva ejector, you are ready to go. We have received a lot of positive feedback and are thrilled that many top dental professionals and schools see the value of our product. It's your turn to reap the benefits. We have been fortunate enough to win several awards, including Hygiene Product of the Year. Practitioners can benefit from automating intraoral fluid and splatter control in a hands-free device. It also has integrated true backflow protection. It reduces chair time and improves practitioner ergonomics. Long-term exposure to aerosols is a health issue. This is comparable to not brushing your teeth on a regular basis. The first time you don't brush your teeth, it's not that big of a deal, but not brushing your teeth over long periods leads to oral health issues. Similarly, being exposed to aerosols on a long-term basis will start to cause long-term stress on your respiratory and immune system. Additionally, implementing different types of aerosol suppression devices can be taxing ergonomically on the dental practitioner. What is the solution? Our solution is the Aerosol Assist system, which is an ultra-lightweight, hands-free, autoclavable, extraoral system that removes intraoral fluids and provides high-performance aerosol suppression during procedures. The Aerosol Assist is designed to work in any office, but we have identified some challenges that your operatories might have when first learning how to use the Aerosol Assist. Making sure you understand the following concepts will make the learning process smoother. The saliva ejector. From falling off, being picked up by patients due to it being uncomfortable, or by it just doing its own thing after you find the optimal position, it is long overdue for an upgrade. The Aerosol Assist is designed to upgrade the functionality of a standard disposable saliva ejector so that it can be truly customizable, comfortable, and easy to use. The saliva ejector is one of the most used tools in dentistry, so why not make it as efficient as possible? Can any saliva ejector work with the Aerosol Assist? Yes, but we do have a favorite. We video reviewed multiple other brands of saliva ejectors for your benefit. The video explaining our criteria on saliva ejector rankings can be found on our setup page on our website. You can also download a PDF to see our favorites. We found that the right saliva ejector makes such a great difference that we started using them in our offices as it made our professional lives a lot easier and the patients enjoyed them as well. The Aerosol Assist is designed to fit a standard HVE connector. If the Aerosol Assist is not snug when you place it on the HVE, the O-ring is probably missing or needs to be replaced. Missing or damaged O-rings are common and cause the Aerosol Assist to not attach. Visually verify that the O-ring inside the HVE is intact to ensure you are ready to install the Aerosol Assist. The Aerosol Assist is designed to allow for easy rotation while remaining fixed on the HVE. We recommend positioning the Aerosol Assist on a dental team member before using it on a patient to make sure positioning is correct and comfortable. When used properly, it should be very comfortable and most patients will not even realize you are using a new device. When sitting the patient, it is important to have them in a supine position and make sure there is sufficient room to allow the HVE hose to fall in between the headrest and the chair. The HVE hose should be perpendicular to the floor and patient. Sitting them at a 45-degree angle can be done, but you need to make sure there is enough slack in the HVE line to not cause any additional tension in the line. It is not recommended to use the Aerosol Assist above a 45-degree position. The Aerosol Assist is a very simple device comprising of two channels. One is dedicated to removing intraoral fluids. The other is a 35mm aerosol port at the top, dedicated to removing aerosols and splatter during procedures. It is a hands-free device hanging onto the patient's lips via the curved buccal plate. It can also be used in conjunction with a bite block. The Aerosol Assist is designed to complement other infection control techniques and systems and works great with cheek retractors, rubber dams, bite blocks, ultrasonic scalers, high speeds, intraoral cameras, intraoral scanners, and lasers. What you see here is what we call aerosol visualization testing. The same setup is on the left and the right. You have the same lighting, the same scaler at the same setting. And what we're doing is we're benchmarking their success against the standard saliva ejector. Notice on the right, as we move the scaler around the perimeter of the patient's mouth, little to no aerosols are accumulated, with the few getting pulled directly into the device. On the left, the patient has more splatter visible, and you can see the change of direction of those aerosols from the scaler as the patient breathes. This is something that is not easily visible to the naked eye with normal lighting. In this splatter visualization testing, we use a non-toxic fluorescent dye. It is run through the scaler, and then we flooded the operatory with black lights in order to more easily visualize where the aerosols are accumulating and to see if we were effectively doing a great job in reducing them. Notice the patient on the left and the accumulation of splatter on the patient's cheek, ear, neck, and hair. You can also see accumulation around the nasal passage, which will indicate inhalation of aerosols. When you compare that to the right, where we have the aerosol assist in place, you'll notice there's almost no accumulation of splatter on the patient's face, nor on the practitioner's hands and tools. The practitioner has both hands free to use their mirror as they've been used to, with little to no change in their workflow. The aerosol assist is a very versatile tool and can also take care of fumes generated by laser procedures. What you'll see in this video is a fibroma being removed. On the left, you have the aerosol assist, and on the right, you have no aerosol suppression implemented, only a saliva ejector. You'll see the drastic difference in the amount of fumes that are generated on the right versus the left. The aerosol assist is able to very quickly and effectively suck in these fumes, keeping the practitioner safe. Looking closely at the video, you see some of the plumes jet into the aerosol assist. These fumes are very toxic. There is a study in JAMA Dermatology which states that laser plumes have been shown to actually transmit diseases. The research states that strict care must be maintained by the laser practitioner to minimize potential health risks, especially when treating viral-induced lesions or patients with viral diseases. The aerosol assist allows the practitioner to use both hands. This allows them to focus on the procedure while automating intraoral fluid removal and aerosol suppression. After each use, the saliva ejector is discarded. The aerosol assist is then rinsed internally and externally to flush out any debris. The HVE port has 2 internal channels that can be cleaned with a standard brush. The aerosol port has access to those same channels and should be cleaned as well. After rinsing, they can be ultrasonically cleaned in an enzymatic bath and then placed in standard sterilization pouches. Load them single file on the autoclave tray and insert the tray in the top slot only. It's important to not place any other instruments or trays on top, as this may warp the device. Do not wipe it down with alcohol cavity wipes, nor dry it in an instrument dryer prior to placing it in the autoclave. The aerosol assist demo units do not come with a warranty. However, a full kit comes with a 6-month manufacturer warranty. If the aerosol assist cracks or deforms within 6 months of purchasing, please contact the aerosol assist team via email with proof of purchase for a replacement. The aerosol assist is able to treat patients with limited ability to open, TMJ issues, pharyngeal or gag reflex, and is the go-to choice for prophylaxis, SRPs, anterior restorations, crown cementations, endodontic procedures, procedures that use a rubber dam, implant placement, and second-stage surgeries and extractions. At around 30 cents a use, it is the most affordable option because of its reusability. You will benefit from the aerosol assist from the first time you try it. However, we recommend using it multiple times with different procedures to have a better understanding of how it works in different scenarios. It is a tool that can be learned easily, and once you see its benefit, you will want to have it in your armamentarium. The aerosol assist is the only system to simultaneously remove aerosols and intraoral fluid removal in one hands-free device.
Okay, everyone, please post your questions for Dr. Arguello. And I want to remind you all there is a banner at the top of the screen, and if you tap there, it will take you to their website. And Dr. Arguello, could you let them know what the promotion that you may have going on?
Absolutely. The promotion is the 20% off if they have the code for Dental CE by March. And then
Okay.
we'll email everybody with that code.
Okay, great.
And that's going to run through the entire March, so they can go ahead and show it to, I guess, all the different clinicians or anybody who's going to go ahead and actually purchase.
Great. So if you tap on that banner at the top of the screen, you can bookmark that to your device and take it back with you tomorrow. And let's see if we have any questions. Dr. Arguello, can you talk about ages that you feel this works the best for?
Yeah, we try to go ahead and make this device as universal as possible, so that the age question or the size, what size mouth or what age person can use it for becomes a little bit less relevant. But obviously, there's going to be extremes. Like, for example, somebody that's very, very small, I wouldn't necessarily recommend anybody under the age of 5 using it. But I think anything's going to be a little annoying for somebody under the age of 5. And it has to do more because of the size of their mouth. It usually limits how the saliva ejector going into the aerosol assist, and then you can't necessarily put it as deep into the aerosol assist as you would want to because they're so small. And then on the other end of the spectrum are geriatrics. Today I used it on somebody that was 80 something, and it was fantastic. It worked really well. So when I say the end of the spectrum, I'm specifically talking about when the tissue, more than anything else, is very delicate. I'm talking about the people who, like, for example, with a mirror, you're able to go ahead and damage the gingiva or the mucosa. But again, anything is going to go ahead and hurt them at that point. So those are the things I would worry about more than anything else, or just pay attention to.
I was on mute. We had an Amazon driver that went by, but I could hear everybody. All right. So for older adults, I guess the concern is just frailty of the skin or friable skin, right?
Mm-hmm. Yeah.
Okay. We have some questions here coming in, so I'm going to make sure that we address them all. Question from Carlami. As a dentist, can I purchase these on my own to bring with me while temping?
Yeah, absolutely. And that's actually one of the biggest reasons we try to go ahead and make it so it's universal, so that in case somebody does have to go to different offices, it's not something you would have to make sure that they have special devices or special hoses. A light hose would make it a lot easier because there's 2 different kinds of hoses that currently exist: the corrugated hoses, which are like very light, and then the typical aseptic hoses, which are really nice, but because they're very clean, and easy to wipe down. But the only problem with that is that they have to go ahead and maintain its structural integrity by being very thick, and that thickness ends up being a little bit heavier. So if you do have those older hoses, I would probably recommend that the patient is a little bit, instead of completely supine, to angle the chair a little bit more. That way the actual friction from the hose is able to go ahead and give you a little more support.
Okay, great. Question, is it available on Henry Schein or Benco?
It's available in Benco. I think it's available in every single distributor. The only distributor that actually is, at this moment, doesn't is Henry Schein. So that's the only one that doesn't.
Question here is, what type of materials is the Aerosol Assist made from? Because it's autoclavable?
Yeah, well, the actual material, I got to go remember. It is a kind of plastic, but it's I had no idea when we were designing this device how many types of plastics there are. There are plastics that are able to go ahead and actually be implanted in the human body. That's the kind of plastic that it is. I think it's considered like a stage 4 or a class 4 kind of plastic, where it's not going to go ahead and cause any inflammatory reaction on the body. So if you're not going to implant it, but they make devices where it gets implanted using that same material, and it can withstand temperatures that are in an autoclavable range. So even though it can go ahead and withstand the higher end of autoclavable ranges, we'd still recommend going on the 30-minute, which is at 125.
I want to, again, remind everyone, you're talking about 6 of the devices, right, per kit?
Yes.
Okay. And the normal price is how much?
It's the normal price, I think, is $299.
$299. Okay. So you're getting a device that you get maybe up to what, 300 uses, did you say, if you autoclave it correctly?
Yeah. 300 uses is, I mean, I've used mine much longer than that. It depends on how you take care of it.
Right.
But yeah,
if you're calibrating your autoclave, that's a good start too.
Exactly.
Right. So you're getting a lot of uses for the price. I mean, it brings the cost so way down. And it's much better for the environment. You're not throwing plastic, into landfills. And that's what I love about it. A question from Melanie, does it prop the mouth open?
No, but that's actually the reason we did it that way. We didn't want to go ahead and have a bite guard or a bite block integrated with it. Although you can use those typical bite blocks that have a channel that goes through it that separates the maxillary and the mandibular to allow the saliva ejector to go in between. And it works really great with I prefer it for some for longer appointments. I prefer it with a bite block if the patient can tolerate it, of course. But we made it so that it doesn't necessarily need to use it, because a majority of patients, that's the number one complaint from the patient's perspective. Obviously, from the clinician standpoint, it's fantastic when they can tolerate it.
There's a question here. Do you plan on designing it with stainless steel or metal?
So that's a really good question. The two issues with designing it in that way, aluminum is actually what we were thinking about because it's the lighter version of it. The only issues has to do with manufacturing. When you actually, the actual complexity of the device itself, the geometry of it makes it so that you have to essentially weld in this, like using ultrasonic welding tool. And the ultrasonic welding tools work really well in, with this kind of plastic. There's actually a different kind of plastic that we want to go ahead and use that's a lot more durable, called Radel, but unfortunately it didn't work well with the ultrasonic welding process. So with the metal ones, that's not necessarily possible at this moment. We're still trying to go ahead and tinker with the actual design to see if there's different ways to do it. But that's going to be next, hopefully.
Question here from Christina. How do you determine when you need to replace the device?
Either it's going to go ahead and have a crack down the seam. We see that happens between 6 months to a year. And normally if that does happen, before, like let's say, somebody puts in the autoclave for at 300 degrees, we still replace it. So that's not going to be an issue. So if aesthetically is going to probably be the biggest key indicator, specifically if it fractures down the midline.
If you see micro cracking or something like that, like with other plastic devices you use.
Exactly.
I wanted to also mention too that it has a built-in retraction device. So if you are treating children and they tend to put their lips around the saliva ejector, it's protective that way too, which is pretty cool. Yeah.
And again, even if it did fracture and aesthetically you wanted a new one, just give us a call and we'll send you a different one if it's within that 6-month warranty.
Within the 6 month. Okay.
Yeah.
All right. Any other questions or comments? I know it's been a long day for you, Dr. V, back there, toiling away in Miami like you do.
Exactly.
So I want to thank you for being here. And I want to remind everybody to tap on the banner at the top of the screen, bookmark it to your device, and then you can reach out tomorrow and show it to your employers as well. The link is also in the handout. And we'll go ahead and close out. So have a great evening, everyone. At 7 o'clock, thank you, Dr. V.
Take care.
We'll see you Saturday. I want to remind everybody, too, that the quiz is going to be sent to you here in about 30 minutes. We do have to audit this class and make sure everybody's attended that was supposed to. And if you have any questions, you can reach out to us. So look for our email in about 30 minutes with the quiz link. I want to thank you all for attending. So tomorrow is a course, I think tomorrow's on tobacco, quit. And Saturday we have a course on infection control. So please be sure to go to the website and be looking for that email in about 30 minutes from our email, support@dentalce now. Bye now.